Good morning and welcome to COVID-19 Talk with local health authorities. Joining us is Dr. Erica Brown, representing Harris County, Dr. David Purse, representing the City of Houston. Special thanks to our producers, David Castillo and Priscilla Key, and a very special thanks to Kathy Finninger, past president, Rotary Club of Houston, who provided us with these questions. As a matter of fact, we were talking earlier, it seems like questions are not only coming in regarding COVID, but also monkeypox. And these are our local health authorities, and so they're certainly prepared to answer any questions related to public health issues. Current status, any change to symptoms list?
So I'll take that one. So really not so much. So what we're finding with what's going on now in the community is we're seeing more BA4, BA5, which is another variant of a subvariant of Omicron. And what we're seeing is not a lot of change. The one thing is probably notable is that there seems to be less of a problem with the loss of sense of taste and smell than we saw with earlier. But for the most part, the symptoms are the same. Now, the big change, if anything, has been that the severity of illness seems to be less. But that's what I had to. That's how I would respond to that.
Are home tests accurate for each new variant?
So in general, they are. There's some caveats to that in terms of some tests being more efficacious than others. But in general, home tests, just understanding the science of it, home tests are looking for the peak of infection. So in general, regardless of the variant, they work pretty well, but there are always possibilities that you're either testing too early or maybe a little bit too late. So there could be some false negatives in that as well.
You know, that's a point that I think we need to emphasize, because I've gotten several calls and said, you know, I need to go and get tested. I was exposed yesterday. It's like, wait a minute.
Right. Not yet. That's too soon.
Yes. Wastewater.
So the wastewater continues to rise. I think this is important. So we're up to 709%, to remind people that we picked the peak of the first wave back on July 6, 2020 as an arbitrary 100% value. And the reason is the units of measure we use are this big, long, huge number with a bunch of decimal points. Wouldn't make any sense to anyone. So we're now up to 709%. That's 7 times what it was back in the peak of the first wave. Well, what's important is it continues to go up about 10% every week. And that's the takeaway, is that the value is high and it's continuing to rise. So, you know, we're far from over yet.
Current percent of people being hospitalized for versus with COVID.
Yeah, so unfortunately, we still don't have a specific answer for that. Obviously, we know that people are hospitalized and they have COVID infection. Those that are coming in with COVID, anecdotally, just in talking to our hospital partners, is increasing a little bit. But in general, it's very hard to parse out who has other chronic disease states that are bringing them into the hospital versus those who are coming in with COVID. Because again, at this point, for safety reasons, everyone is being tested for COVID who comes.
CDC says BA5 now accounts for over 50% of your cases. Has it been proven that BA5 has greater severity? Is there any projection of how BA5 will grow?
So BA5 is growing in our community. Now that 50% value across the United States, remember there are places like New York that are ahead of us. So what I'm hearing from our hospital partners is that we're just a little bit below 50%, or maybe a third or more is BA5, but it's going to grow. And the reason is not that it makes people sicker, but it spreads more easily. So the severity of BA5 doesn't seem to be any different, but it spreads so much more easily that's why it's growing. And we can expect to see more and more cases of BA5 as time goes on.
Do people who have COVID early have more or less resistance to Omicron?
So that depends on a couple of things, more or less compared to those who didn't have infection or compared to those who were vaccinated, or both. So the bottom line is, whether you were infected before or you got vaccinated, that is providing you some level of resistance to the next infection, including Omicron. Now, Omicron, and in particular BA4 and BA5, are sufficiently different from the previous versions and from the vaccine that people are getting infected and they're getting sick Many people are getting sick enough that they won't go to work, but we're not seeing the increase in hospitalizations at the rate we saw before. So yeah, if you were infected before, it does provide you some protection. But Omicron is or BA4 and 5, I should say, are pretty crafty. So people are still getting symptomatic. They're just not getting as sick. Now, if you're unvaccinated and you were never sick and you get BA4 or BA5, you can expect to get just as sick as anybody else would have a long time ago.
I had COVID while pregnant. My baby is now 6 months old. Should she be vaccinated? Do antibodies last longer in infants?
So this is the opportunity for us to put in a shameless plug as local health authorities for all children who are eligible to become vaccinated. Unfortunately, COVID-19 has become a leading cause of death in children. And I think we need to be very aware of that. Although for most, it's a less severe illness at this point if you've been vaccinated. It has risen on the scale of causes of death. So to answer this specific question, absolutely your 6-month-old should be vaccinated to protect them. Immunity is immunity, regardless of the age. So I can't say that the immunity lasts longer, but it will provide protection. We know for a typical average of about 6 months, and it's important to know that the baby will not have full immunity, just like with adults, until they have had a full primary series and are 2 weeks out from that. Okay, so I'm not going to get into the specifics about each vaccine and how many doses, but I would highly recommend that all children 6 months of age and older be vaccinated against COVID-19 because, again, it is a leading cause of death for children now.
Thank you. For those not eligible to receive initial vaccines, which one seems to work the best in current conditions? Said we weren't going to get into that. Go ahead.
Yeah. Yeah. So really, there's not a whole lot of difference. They're all working pretty well. Remember, when a good vaccine will have about a 60-70% efficacy rate. So we all got spoiled with these 90% rates. So keeping it real, they're all pretty good. But as time goes on, one thing to keep in mind is that if you mix and match, that does seem to give an advantage as opposed to sticking with one brand as you get more and more vaccines.
What about multivalent nanoparticle-based vaccines? It's been reported that a single immunization abolished all infectious virus within the lungs after a single dose in hamsters.
So this is a little bit complicated. So nanoparticle based vaccines are based on literally the shape of the particle. That's how they work to get into the cells and to produce an immune response. First of all, it's not going to come for a little bit of time because it's still in the development phase, but it does appear to have a little bit more efficacy in eradicating the disease in the early stages and providing some immune response. The studies that were done were not necessarily to create a nanoparticle vaccine to compete with other COVID vaccines, but rather just a different mechanism for a different type of COVID vaccine. And again, really based on the shape of the particle as opposed to an mRNA or an RNA replication.
What about the importance of nasal vaccines to promote mucosal immunity and help block the transmission change?
Yeah, so the concept of nasal vaccines is not entirely new, and we will see how they work. But the concept really is that where people would get the vaccine administered through their nose, and since we know that a lot of spread of COVID is because you breathe it in, that if we wind up with having greater protection in those nasal passages, that you may, as the person writing the question, break the transmission. In fact, hopefully you wouldn't get infected at all. So this has yet to be proven, but it's an interesting concept and it's not entirely new. So we'll see where it goes.
New York City is offering Paxlovid at mobile testing sites so people who get positive results can get the medicine immediately. Is that being considered here?
So Harris County is not currently considering that. Just today, as a matter of fact, overnight, the information was released that pharmacists are now able to prescribe Paxlovid However, in Harris County, in particular, we have not started that program.
And we haven't either on the city side. Seems like some people are getting COVID multiple times after taking Paxlovid. Should it be taken longer, a higher dose?
Yeah, so this is a great question. So the phenomenon is that people are diagnosed, they're prescribed Paxlovid, they may have some mild symptoms, are prescribed Paxlovid, they get better, and then after they start taking the medication, that the symptoms come back. So a couple of interesting things about that. One is that phenomenon of having mild symptoms getting better and then getting sicker again, that is seen in people who aren't given Paxlovid as well. So it's not just in this group. It does appear to be occurring more commonly in people who are given Paxlovid, but in that text, what it may very well be is that it is working just exactly as it's supposed to, keeping the infection at bay, and then when you reach the limit of the medication, that the virus then has a chance to come back. So it's not that the Paxlovid didn't work; it's just that the virus worked longer and harder, and so that's what we're seeing now. In terms of should be taken longer and at a higher dose, those are great questions the manufacturers are looking at. You have to worry about the complications of the medication, and I don't have the answer to that yet, but I'm sure the manufacturers are looking at it because there would be a more effective treatment if they, and quite honestly, it's a great business model if they give you more of it for longer. So I don't have the answer to that.
Harris County Public Health shows some racial and ethnic minorities communities have been disproportionately affected by COVID-19. Is that due to vaccine access or other risk factors?
This again is a really great question. It is multifactorial. Some of it has to do with access, which is why public health and the city have taken great efforts to take mobile units out and kind of do pop-up shops for vaccination in all areas of Harris County. So yes, access is one issue. Education about the vaccines and understanding about the vaccines is another issue. There definitely are some gaps in health literacy among those who are underserved, and so we're really trying to push efforts to make sure everybody understands the need and the importance of getting vaccinated. And then again, there's some economic factors that play into that as well, and some again under health education, perhaps not knowing that the vaccine is free. And so as much as we've been promoting free vaccines and been trying our best to get out to all areas, there's still some who are being told from various entities or are not used to, right, free medical care. This is something that's new for all of us with this pandemic. And so again, it's multifactorial, but we were really trying to do our best to get out to those who are disproportionately affected and welcome any suggestions and frankly, any free advertising that you can provide to assist us.
Absolutely. Since COVID seems to be impacting the vaccinated, what about the unvaccinated?
Yeah, great question. So remember we said earlier that BA4 and BA5 are now sufficiently different that they are able to infect people who were previously vaccinated or previously infected. Those who are unvaccinated remain clearly at increased risk for having more severe illness. I'm talking about unvaccinated and previously uninfected. They're at the greatest risk for getting the most severe illness. Now you're going to hear from the hospitals that a majority of folks who are being admitted with COVID are vaccinated. That is misleading. Of course, that's the case. We're pushing 70-80% of the adult population is now vaccinated. So, a lot of the folks, as mentioned earlier by Dr. Brown, a lot of the folks coming into the hospital are coming in because of their appendicitis, their infarcted bowel, their pancreatitis, their kidney disease, and they're testing positive. And a lot of those folks are vaccinated. So the bottom line here is that if you're unvaccinated, especially if you're unvaccinated or never infected before, that is your highest risk, folks, for having the worst outcome if they get infected now.
What are your thoughts about the inevitability of infection?
That's really complicated. As many, I think there are two ways to answer. Number one, I think we need to be very clear that we're still in a pandemic across the world, in the country, in Harris County. Millions have been affected. Having said that, when you look at that number as compared to the number of people in the world, technically it's not a huge number. So if we're talking about in relationship to the susceptibility and the ability of the variants to spread, right? We're in a phase where we have variants that spread more easily, but isn't inevitable for everybody. I don't think that is perhaps an accurate statement when we just look at the raw data. But again, it does not diminish that in context to other previous illnesses, and not having had a pandemic in our lifetime. Is this a huge number? Absolutely, it's a huge number where we've had some devastating consequences.
Will there ever be such a thing as herd immunity?
Yeah. Well, do we think we'll ever achieve herd immunity? The reason we haven't achieved herd immunity so far is because the new variants have come along and to some degree put us back to square one. So as long as we continue to get more variants, it's going to be a challenge for us to reach herd immunity. But could it happen? Sure. You got to remember, all of us have got to do our part to slow this thing down if we want to reach herd immunity. So long as we continue to spread the virus. And what we really think now is happening is that most of the new variants are coming from folks who have got these longer illnesses. Those tend to be the folks who've got, some immune system problem where they don't get rid of the virus right away, therefore a longer time for a new mutant to occur. But that person got infected by somebody else. Every one of us has our part in the solution here. So,
in some countries and areas of the U.S., it appears COVID numbers are declining. Is this just a decline of one variant with another getting geared up?
Yeah, great question. So when they report the COVID numbers in a country or a part of the United States, that's all the COVID infections that are currently occurring there. To the best of the ability to measure it. Remember, a lot of folks are testing at home. It's not getting recorded. So when we talk about the numbers, it's a guess at this point, but you can tell which direction things are going. And there is this wave phenomenon. So while the numbers are declining in some areas, I expect that they will decline. Now, does that mean we're not going to have another wave? Absolutely not. So we're probably our fifth wave. If we get another variant, there'll be another wave.
Is there some reason the second boosters are not recommended for healthy people under the age of 50? Shouldn't we just use them to vaccinate anyone who wants them rather than watch the batches expire?
So no. So a little bit of background on how recommendations are made for any medication. It really has to do with the risk versus the benefit of taking the medication. So at the point where there is shown to be no additional benefit to the medication and or the vaccines, meaning we're not going to get any more increased protection from it. There may be, not in this case perhaps, but there may be increased risks when you start adding on doses of things. And this is for any medication, any vaccine. The medical society weighs the risks versus the benefits. And so in this case, there's no added benefit to adding vaccine to those who are healthy and under the age of 50. So the highest level of vaccine is what is currently recommended. So, it's a risk versus benefit, and we never want to encourage taking more than we need to for the health benefit of those in the community.
So it's about who's at risk.
Correct.
How long do you have to wait after our second booster to get a bivalent when available? And when the new bivalent comes out, will this negate the need for boosters 3 and 4?
Great question. So they're not out yet, so we don't know what the recommendations are going to be. So I'm going to make a prediction that it'll probably be a 4 to 6 month recommendation after your second booster before you get the bivalent. That's a prediction on my part. And what I've said is, you want to make a mistake in public health right now, make a prediction. So let me go ahead and make a prediction. So I think it'll be a 4 to 6 month window. And will it negate the need for boosters 3 and 4? It probably will, because it's bivalent, which means what is in the boosters right now, which is against the original strain, will be in the new one that comes out. Now, there may be a recommendation that you get the bivalent, a series of 2. We'll have to wait and see, but you won't need to get, if you haven't gotten 3 and 4 yet, and you're going to wait for the bivalent to come out, it's probably going to start your series over again.
Okay, please weigh in. Natural immunity versus vaccination.
Well, I think that with what what the data has shown is that natural immunity, if you got infected, you got natural immunity, that actually did provide you a little bit better protection than vaccination in the beginning, the first series. I'm going to jump ahead here. Natural immunity plus vaccination, that is clearly the best way. If you were infected before, you should go ahead and get vaccinated now. That is clearly superior to either immunity or just vaccination alone. Now, that is not to say that if you're vaccinated, go out and try and get natural immunity. It only worked, I shouldn't say it only worked, but the observation where if you got sick first and then you got vaccinated, that gave you better protection than just being sick alone.
Natural immunity plus vaccination plus booster, even better.
Even better. You got to remember that, it winds up being a combination. So this gets really complicated. So we talk about the antibodies. It gets a lot of traction in the media about the number of antibodies and the levels of your antibodies and how long those antibodies last. But there's another part to your immune system. So, throughout your lifetime, you get infected with lots of things to which you produce antibodies. And shortly after infection, you have a lot of these antibodies. Well, then that's what's called the humoral immunity system. But then there's a cellular immunity. We talk about these T cells and B cell immunities. That's like the long-term memory. And so with your multiple vaccinations, that's where you develop the long-term memory that will protect you. If you didn't have that, and every time you got infected with something in your lifetime, you developed a whole bunch of antibodies that floated around your blood. By the time you get to be like 20, 25 years old, your blood would be so thick with antibodies, we would all die. So you have to get the long-term immunity with the T and B cells, and that comes with, getting vaccinated and getting boosters. And if you should happen to get infected, that will lend to you developing that long-term immunity that you need.
Is anyone tracking long COVID rates in the area?
So there are absolutely studies and tracking being done, not necessarily specific to our area, but across the country in general, to really try to better understand long COVID. There are numerous methods that the CDC is using. So the answer is yes, there is tracking because we're still trying to understand, but it's not necessarily specific to a region.
Okay, another one for you. On Harris County public posts of long COVID condition, it shows women at risk. Why higher than men?
Yeah, so again, this is an area that is still being studied. We're not really clear on why that is. We know that is because the data is showing it, but we're not really clear on the why. There be hormonally, and then with that affecting immune system, sometimes, especially in pregnancy, women can be immunocompromised in pregnancy, and then again, at certain hormone levels and things may affect that. That may have an impact for women. But again, this is an area, as with some other things, where just in general, for some reasons, men are more affected with some things, women are more affected with others. This still needs to be studied.
Okay. Looking at the time, I'm going to break and do other news for 2 questions, and then I'll come back to COVID. Monkeypox outbreak strains has more mutations than expected. Implications.
So with the monkeypox, there's two clades. There's the Congo and the West African clade, and so in terms of mutations, it's really early to say. Here's the other thing: monkeypox is a DNA virus as opposed to COVID, and everything right now in the public we're relating to COVID, which is an RNA strand. So DNA viruses, they don't mutate very often. It's very difficult because you have to have a mutation on one strand has to be matched with a matching mutation on the other strand. So it doesn't mutate nearly like COVID mutates. But anytime we do get a mutation, the more people who get infected, the more likely there is to be a mutation. And we saw that with COVID. Unfortunately, we may see that with monkeypox as well. And with the new mutation, there are new characteristics. So the idea is we really just need to stop this spread now before we create more mutations that create more problems.
So we're really putting you health authorities at test. We're going to jump to West Nile now. West Nile seems to be making an appearance. Please provide information and cautions. We've been there before, haven't we?
Yeah, we have. So West Nile virus, the host vector is traditionally the mosquito, right? Signs and symptoms are flu-like symptoms, similar to a lot of other things, right? So the key here is if you are experiencing flu-like symptoms, you've had recent exposure, as many of us, especially living in Texas, have had. You've had recent exposure and a love tap from mosquitoes, to go to your primary care provider and get tested. That being said, for most, West Nile virus, just like most things, is self-limited. Now, I'm not going to say that you feel great while you have it. You certainly feel like you have the flu, body aches, fever, chills, etc. But for most, it's self-limited. There are some who experience longer symptoms and can even experience some transient paralysis called Guillain-Barré syndrome. That is a rare condition, but obviously if you are beginning to experience some abnormal symptoms, the best thing to do, again, is to seek care from a provider. Dr. Peirce, did you have anything that you wanted to add?
No, I just, the usual at-risk populations, the elderly, the chronic illness, infants, those are ones who are at greater risk for having the complications, and they can be severe, as you've described. So, protect yourself from mosquito bites all the time.
Well, how would an average provider actually know to test for West Nile now? Especially now, we have COVID, monkeypox.
That's a really great question. And similar to monkey, so not so much COVID right now, but monkeypox and West Nile really is more of a diagnosis of exclusion. There's so many more common things that can happen that those should be tested first. So for instance, flu should be tested first. We are moving into flu season. COVID should be tested first. Other bacterial infections that can cause similar symptoms, perhaps depending on the presentation, depending on the age of the patient, et cetera. Again, there are common things that common is always more common. But once you've tested and those things are negative and you still have a symptomatic patient, then you begin to look at other diagnoses.
Well, that's the end of our time. And I really appreciate the way that y'all have answered the diversity of questions that really came out of Kathy's list. Thank you for joining us for COVID-19 talks with local health authorities. Dr. Erica Brown representing Harris County, Dr. David Peirce representing the City of Houston. Special thanks to our producers, David Castillo and Priscilla Key. Special thanks to past president, Rotary Club of Houston, Kathy Finninger, who keeps really bringing the questions in, not only about COVID, but other public health issues. I'm Stephen Williams, Director of the Houston Health Department.